Hello everybody and welcome to this week's Infection Control Matters. It's Martin Kiernan here, and I've been lucky enough to be on my travels again. I was recently at the IPAC-Canada meeting in St John's in Newfoundland. There were a couple of posters presented at the meeting that really piqued my interest, so I managed to track down the authors and we had a bit of a chat, so I hope you enjoy listening to our discussions.
Okay, it's Martin Kiernan here, and I've come across a poster at the IPAC-Canada meeting, which I really did like. And it's something I'd never really thought about. And the poster's called A New Approach to Hiring Environmental Services Attendants. And this is from Peterborough Regional Health Centre. I'm delighted to say that Margaret Cameron, who presented the posters, here with me. And I thought we'd have a really nice chat about this, because I thought this was a really nice, innovative approach. It may be actually what people do routinely, but I suspect not. Tell me about the issue first. Your facility is about 450 beds, something like that?
Yes, at the time into 2017, when we switched our approach to hiring environmental services attendants, we were about 450 bed acute care hospital, community care, not research, and serving a broad catchment area.
Okay. And the issue was what? What made you think about changing? Because previously you'd done 1 hour interviews.
Yes, the traditional 1 hour interview where you ask, 20 questions or so to the applicant, and whoever answers the questions, gives best responses are usually who you hire. And we did find that we were hiring people and they weren't, after training and orientating them, they would not necessarily stay. So we invested a lot of time and energy, and people would leave. We found we had lots of vacancies coming up due to retirements or people switching over to work in other areas of the hospital. And it was very labor intensive to spend a lot of time and energy interviewing and not getting the best candidate for the job.
Yeah. I mean, if you're only getting a 1 hour interview, you don't get any flavour of what the job's like unless you know somebody.
Exactly.
Who would tell you. So I take it was your human resources department who flagged this up, and was it them who prompted, can we go about a different approach? Or
Yes, we are talent acquisition specialist in our human resources department decided that this might be a good approach to try for environmental services. They had already done an initial one with RPNs, registered practical nurses, in our facility, and they wanted to build on that to see if it worked for the environmental services attendant role.
Okay. That's interesting. So who was involved in deciding what the scenarios were going to be? Because you had a longer period of selection day. It takes a day. So who looked at, what are the key skills that you want from the environmental services workers?
Yes, so the first thing they did was they put a group together. So it was comprised of human resources, environmental services management, environmental services frontline workers. And because Infection Prevention Control has a very good relationship with our environmental services, I was also invited to the table.
Yeah, excellent. That's really good. Because your cleaning service is in-house, is that right?
It is an in-house. They are employees of our facility. We do not have contracted workers for that.
Okay. But no reason why a contractor couldn't do this?
No, there's no reason why they couldn't as well.
Okay.
So the first thing we did, we had understanding of what a multiple mini interview process was like. We learned about the concept for multiple mini interviews. And the next step we decided, actually we came up with the premise that we could train anybody how to clean and disinfect.
Yeah.
That was something that was a trainable skill. Yeah. And we decided we needed to look at what other key skills do we want our environmental services attendants to have. And we did brainstorming around that. And the 5 key essential skills that we decided upon were they needed to have computer skills because technology was changing, and that was also going to be part of their job, especially as we integrated into electronic bed transfers or discharge cleaning apps, as well as we wanted them to have empathy. Sometimes the cleaner spends more time in the room with the patient than other people in the healthcare team. And we wanted them to be patient-centered and make sure that they would have a good rapport with patients, as well as being attentive to detail, being collaborative and a team player, willing to help out their coworkers, and being able to multitask and prioritize work.
Okay, so that's a nice skill set. And I'm not sure you definitely would, no chance, tease that out within a 1 hour interview, I don't think.
Definitely not. No. We've been told, some people we have found answer very well on the questions, but when you get them in and they actually are doing the work, you realize that you do have a mismatch there.
Okay, yeah. And plenty of people freeze up in an interview where they don't get ready to, the chance to shine, as it were.
Exactly. It can work that way too. Some people are very, get very intimidated by that environment, and they may have great skills, and we just don't get to tease it out in that situation.
Okay, so how does the multiple mini interviewing work? Because it's a multi-stage process, isn't it?
It is. So it's multiple mini interviews, but we do call them MMIs for short. So we initially set it up with 8 stations. There were 2 rest stations. We had started with the traditional interview station, a scenario station, 2 simulation stations, and 2 task stations, and they were alternated around in our setup. So it would initially all the applicants would come in. So we would do 8 interviews in about a 1-hour period. All the applicants would be told what the situation was, how the process was going to work, where they would stand in front of a door, read what was going to be expected of them. They would have 2 minutes to do that and get their mind wrapped around what was going to happen once they opened that door. And then they would step into the door and either be asked the interview question, the scenario question, or do the task or the simulation.
Okay. So task or scenario number 1, what was that?
The station number 1 was our traditional interview.
Yeah.
So you can imagine, like, somebody would start at station number 1, but somebody else is already starting at station number 2, right?
It's very time efficient as well, isn't it? Yeah.
And the traditional interview question, tell me about yourself. What's your experience? What's your knowledge and education? Yeah. How does it relate to this position?
Okay, moving then into the next station. What's that then?
Our station 2 was a scenario station. So we would say, you're going into the room to clean a room of a dementia patient. They start yelling at you and asking you to leave the room and are getting upset. What would you do? So we wanted to see, do they understand that people have dementia? How are they going to handle it? Can they de-escalate the situation? So we would, had a grading scale to look at their response.
Okay, that's very nice. So after that, they go to a simulation?
Yes. The simulation, we had on the door that they needed to turn the room around very quickly. It was needed for a procedure, and they had to go in and clean these items. And that was all they knew when they went in. So they would go in, but then we would have another coworker come in and interrupt them. So
this is really like real life.
Yeah, so like real life. And they'd say, chat, oh, I see you're new here. So we wanted to see, are they able to still keep on task, continue to work while having that conversation? Do they stop, work all together? Or do they even, as a bonus, ask that person to help them get the room done?
Yeah, that would be interesting. Did many actually do that, do you know?
Some did actually, yes.
Okay, wow. That's really good. Okay, then they get a little rest.
Yes.
Right, okay. And then station 5 is a task.
Yeah, so this was really just basically to see if you could follow instructions. So it was, you need to go in, clean these items in this order, tie up the garbage bag, and take it out of their rooms.
Okay. It'd be interesting to see how many already worked out, I can shortcut this by doing that instead of that, and not really realising why that there is a particular order. So that would be a good way of testing that. Okay, on to station 6, which is another simulation.
So station 6 was the simulation station. We had them going in to clean a room again, clean these items, but in this case, we had a patient in the room. We had somebody that just loved being the patient. She would come in with like casts on and splints on her fingers and really play it up. And she would ask the environmental services applicant to get her maybe a drink of water or get her a blanket. And it was trying to see how they would respond when a patient asks them for something. Would they acknowledge it? Did they, give them the blanket because it probably wouldn't cause any harm, or did they say, I'll check with the nurse and find out? So just to see how they would interact with a patient.
Okay, that's very nice, actually. And did anything interesting happen in that, or did people mostly find that okay? I mean, because not everyone always wants to talk to a patient.
So that's what we're assessing. We want people to be comfortable. This is the clientele that they're going to be work with. So sometimes people we would have somebody that would totally not respond to them and ignore them. And unfortunately, that just would disqualify them from working for us.
I'm wondering if any of themselves recognised by this stage, actually, I'm not going to like this job and it's not for me, and absent themselves from the procedure, really.
And some did. And that was the beauty of doing the interviewing process this way. Some people actually, by going through these steps, would self-select out and realize this maybe wasn't the job that they were looking for. They maybe wanted something where they didn't have to interact with people. Okay. And that's not our expectation in the hospital environment.
Certainly not in that setting. So then they get a rest, and that's the end of the process?
Yes, that's right.
Okay, and then...
Oh, no, there's one more task. Sorry.
Yeah.
We've missed the computer task. Station 7. Because of the computer skills, so we had directions on how to access our safety data sheets online. There was step-by-step instructions with pictures, screenshots of even the buttons that you needed to click to get there. And it was a question about look up a disinfectant and tell us what personal protective equipment you would need to wear if you were using that disinfectant.
Okay. Right. That's a good one, actually. And presumably they have to then how to read a safety data sheet, that sort of thing.
Yes.
Okay. Excellent. And so then you're going to school them up on this and offer this top few a job, depending on how many. I mean, do you have 8 below this point where you will not take you, even if we have vacancies sort of cut off?
Yes. So ideally, I mean, we want the best candidates for the position. So we did have evaluation sheets. We tried. They were made as objective as possible. Because we wanted to take as much subjectivity out of it. After we went through all our 8 candidates in the period of an hour, everybody would meet from the different stations, and we would go over and talk about the applicants and go around the table for each station and what we thought and how we had graded them.
Okay.
And compare. And sometimes you might have somebody that did very well at one station, but they were so low on another station that unfortunately would disqualify them. Some things, if they didn't have computer skills, if they wanted to go and learn computer skills and come back and reapply again, the HR department would tell them that and encourage them to do that.
To work on, wouldn't it? Yeah.
Yes, and that. But other ones just were not going to be a good fit at all. So you unfortunately, we want the best people to be able to work in our facility and work in this role. So some people just didn't meet the grade.
Okay, well, that's a shame. Any feeling that things have changed and people are staying in the jobs longer and coming into and enjoying the job, and you're not got quite the churn that you would have had previously?
Yes, we don't have any hard data to actually measure. Unfortunately, we've had a bit of change in staffing in the various roles, and some of that data was lost. But anecdotally, they feel it is our environmental services manager. Human resources feel that it has been a positive thing. We are not having the same churn. People are staying longer. The investment is paying off in keeping people in the role. When we would do an MMI, we would probably, instead of doing 32 hours of individual traditional interviewing, we could interview 32 people in an 8-hour day.
Yeah.
And at the end of that 8-hour day, we would have probably about 4 to 12 of those 32 applicants that we felt were appropriate to offer positions to. Yeah. If we had a current vacancy, the ones that scored the highest would get those first offers, and we would keep the rest of them on a wait list. And as vacancies came up, we would offer it to them. Human resources would get back to them every couple of weeks to let them know what number they were on the wait list to make sure they were still interested in the role.
Yep.
And in the meantime, while they were on the wait list, we were also working with occupational health and safety to make sure we were getting their vaccine status and all their immunizations or any other things we needed for onboarding in line, so that once that vacancy came up, we could get them in as soon as possible to orientate and train.
That's fair enough. I mean, I think having a wait list is great, because you're not continually advertising jobs, and then when the wait list presumably gets short, you just run another batch of interviews.
Absolutely, yes.
Yeah, it's really proactive and a really good use of time as well, because you get so many people through in such a short period of time, but you're also selecting people who are appropriate for the job. And I really like this.
We have modified the process a little bit.
Yes.
COVID-19 came, and then of course all this was put on hold with physical distancing and trying to stop the spread. So we did go back to traditional interviews, but in the virtual format, which again is another dimension of challenge on that as well for assessing appropriate candidates. Since then, we used to do this interview section, or with the many interviews with the 8 stations in our medical outpatient department. And we would have to do it on a Saturday when the department was closed. Right. So it was hard to find an area in the facility where you could set up 8 stations simultaneously. Since then, we have transitioned to doing 4 stations in our learning center with partitions up. So they are doing still the simulation with the patient and the simulation with the interruption, and then the interviews and scenario as well.
Yeah, well, I'm using the education centre as a good way of doing it as well, isn't it?
And they could do it through the week and not have to cut into people's weekend time as well for an interview.
No, it's very nice. I really liked it, Margaret. Thank you ever so much for talking
you're welcome.
about it.
The one thing I actually forgot to mention too, we did have one of our, we call them our patient and family partners. So this is somebody that doesn't work at the hospital, that represents patients and families, that would also sit in on the interviews in the process and was part of the MMI.
I'm getting the feeling this is very much, this hospital is very much part of the community. So
it is.
And these are people who will be cleaning their local hospital with their family members going into it as well.
Yes, exactly.
Yeah. Okay. Oh, you did mention one thing, that people get wind of the scenarios because people tell you, so you have to change them around.
We do, yes. Because we are a small community, word of mouth does travel, and we do every now and then have to reconvene and change up the scenarios and find a different way to try and assess if they have those key skills.
Okay, thanks very much. Well, I really appreciate you talking to me, Margaret.
Oh, it's been a pleasure, Martin.
Thank you.
You're welcome.
Hello everybody, it's Martin Keenan here, and I'm looking at the posters and I come across one on an outbreak of surgical site infection related to Staph aureus in hip and knee surgery, and so I thought I'd have a chat with the author, which is Karrie Yausie. Can I ask you just to outline what the problem was and how you came across this to start with?
Absolutely. Good morning, Martin.
Yeah.
Well, long story short, between the months of May and August of last year, so 2023, Saskatoon City Hospital in Saskatchewan noticed a significant increase in the surgical site infections in our elective hip and knee surgeries. Between May and August, the rate ended up being 1.46 compared to the rate of the previous quarter, 0.43.
Yeah. I mean, it's already very low.
Yes.
But so it's still relatively low, I think. Most people in the UK would say that's... But it's a big jump for you.
It's a big jump for us.
Yeah.
You know, when you would compare the rate from 0.43 to 1.46.
Yeah.
17 patients had an infection. 11 out of those 17 cases yielded Staph aureus as the pathogen.
Right.
So suffice to say, I was a little concerned about that.
Yeah. Yeah, that is a bug we do worry about.
Yeah. Subsequently, did a deep dive. So I did a thorough investigation into all the cases. What I first did was I compiled a line list of all the patients that had an elective hip or knee surgery within the months of May and August, between May and August, to determine if I missed any cases. Then I did thorough chart reviews, both electronically and paper, to determine if SSI prevention bundle was complied with.
What's in the bundle? Is that of interest?
Perhaps if they have diabetes, to make sure that the insulin levels are maintained, to maintain a certain temperature, to decrease the chances of infection, and most importantly, to make sure the antibiotic prior to surgery is administered within a certain period of time.
Right.
And there was nothing remarkable that came out of that.
Okay, that's good.
Yeah, so which is good.
Yeah.
What I did next was to see if there was any commonalities, specifically in the OR setting. So I looked at whether or not there was a common OR theater. Was there a common surgeon?
Okay, are you using ultra clean air?
Yes.
Yeah. Okay.
Yes. And then I looked at our other staff members. What I did find was in those 11 cases that yielded Staph aureus, I noticed that there was a common staff member in 6 out of those 11
Okay,
cases.
over half then, yeah.
Yeah. And that staff member was either a scrub nurse or a circulating nurse.
Right, so it's pretty close to the actual surgery itself. Yeah.
Yeah, and then what I found was that staff member was on a hand hygiene accommodation.
Okay.
What that means is that staff member in particular had compromised skin on their hands.
Right.
Who was allowed to limit the amount of time that person needed to wash their hands to prevent any more skin irritation.
Okay.
Meaning that we don't know how often that person washes their hands.
So the occupational health department made that decision?
It was an accommodations department, and they made it in silo. So they made it, we did not know about that.
Right.
The prior manager did try and fight that and was not successful.
Okay.
So...
And accommodations are part of HR, or they're a separate?
They're a separate entity entirely.
Yeah.
And so in conjunction with the family physician, they determined that that was okay.
Yeah.
And during this time, we tried to establish some meetings to discuss this, and it was met with some resistance, but we did. And out of that, we created a work standard for managers to help them follow if some staff member does have compromised skin integrity.
Because that happens, and
absolutely, it does. And try to avoid a hand hygiene accommodation specifically in the oral care.
Yeah, especially if you're a scrub nurse.
Absolutely. Unfortunately, though, fortunately, we were able to send the isolates of all the 11 cases to our provincial lab to get genotyped. And we also tested that common staff member.
Okay. Did you test any of the other staff as well?
No, because there were really nothing obvious. Like there was no common staff member. We didn't do.
So you wait to see the result of all the other staff testing to see if they're separate before we go down the route of swabbing staff, I suppose.
Yeah, it's tricky.
Yeah.
If you want to get unions involved, So we were allowed to test that one staff member because of the fact that that staff member was present during the 6 out of the 11.
Sure.
Unfortunately, all those isolates that were genotyped were unique.
Wow.
So I was at first I thought we got it. We have a source of this infection, which is
we can do something about it.
We can do something about it. And so to date, we really don't know what caused this outbreak. But I want to do what is interesting, Martin, is now we are seeing another increase in Staph aureus.
Okay. And the temperatures
are rising.
Okay. Yeah, because I've been looking at the role of climate and temperature and humidity on surgical site infection recently as part of a talk I've just done. And there's quite a few papers looking at orthopaedics in particular showing that the infection rates go up in summer when temperatures get warm. And I do wonder about, what extra warmth and humidity does to the skin microbiome before you come in, because your patients come in on the day of surgery, don't they?
They come in on the day of surgery, and not all do a pre-assessment clinic visit either, which would provide them with directions on how to prep for that surgery.
So what directions do they give them?
Well, they would be given a soap called with CHG, which is an antibacterial soap, that they would be required to have a shower the night before their surgery, where they apply this soap and they have to let it stand on their skin for a minute, and then the morning of are required to have that same shower with the same soap. With the shower.
Okay. Do you know if the people who got the infections were the ones who didn't go to the outpatients department?
I looked at that as well. After the genotypes came back all unique, I'm like, okay, maybe it's the skin prep.
Yeah.
No, there was nothing common with that well. And I did look at the practices of the OR specifically with their skin preparation technique and all the other practices. And again, unremarkable, all met with compliance. So we feel that it is the patient's own flora that's contributing to this. And we are now looking at screening and decolonizing prior to the elective hip and knee.
Okay. I mean, I do wonder how well the outpatients department puts over to people the need to do this, as opposed to here's a soap and have a wash, rather than this is really important and it can make a big difference to you.
Absolutely. And if I were to hazard a guess right now, it's probably not as thorough as we would like.
Yeah. Okay.
Yeah.
Okay. So a couple of good things came out of it. You've now got a discussion going on with your accommodations department to previously wouldn't have thought to discuss anything with you, so that's good.
Yes.
And
yes.
maybe you're looking at other things. I mean, it'd be interesting to look at temperature, though, and see what impact that does. And
Giving me some food for thought this weekend, Martin. You really have.
Okay. Well, thanks very much. Good luck.
you.
And let's hope you can get on top of this one as well.
Absolutely. Yes. Thanks so much.
Thank you very much.
Well, that's it for this episode of Infection Control Matters. We'll catch you again at the next episode. Thanks very much for listening.